But when we look at the objective findings, we must determine peripheral neuropathy versus spinal neuropathy or radiculopathy. What I mean by that is it in the peripheral nerve itself? Is it spinal in that it could be compressive as a radiculopathy, or is it a spinal problem, which can also happen, especially now with the research showing in whiplash. So all these things with reflex, pinwells, strength, Tinel signs, distalization, these are all important to look at. Anatomical, the second part is anatomical relationship between pain locality and spinal motion segments must match. So if a central problem is what you found, you decided, yep, right at C5-6, and the patient is describing lateral epicondylar issues, including inflammatory reactions, where you can actually find bogginess sometimes and tenderness, redness even, then okay, I can buy that. It's a C5-6 distribution of that nerve. Okay. They may have pain other places, but I find an anatomical relationship of that distalization that happens down the nerve. They must have specific correlation between provoking tests of neural tissue and spinal segments. So if you have an obturator nerve test, and again, remember the obturator nerve test can be done active and passive, and we find that as positive, but the only thing you find centrally is the L5-S1 segment dysfunction. That's where their central dysfunction is. That doesn't correlate. Now maybe their problem is somewhere in a tunnel distal to that. That's fine, but it's not at 2 or 3, and you're not going to treat there. You're going to treat further out. And there must be specific correlation between the palpation tests and provoking tests. So if you have positive ulnar nerve palpation with positive ulnar nerve provocation, mechanical allodynia, you got it. Now, remember, you can have a positive ulnar and a positive median because they share many of the same nerve roots, but you would have one of them that is dominant in everything you do, both active and passive. And when you add and subtract that one, you see changes even in muscle tone and other things. So you can really decide that's it. But that also means that that nerve, because of the hypoxic effect of what's happened to it, should also be more tender to the palpations we're doing. And they should fit. If they don't fit, don't make them fit. You just have to figure out what else is wrong. Sometimes there's more than one thing.